Yes, very well.
That's great. There are a few people that just joined. Well, we are going to discuss the malignant tumors of mesenchymal origin. What is the term that we use for this tumor? Do you hear me? What is the term that we use for malignant mesenchymal tumors? Do you know? Do you hear me?
We hear you, but we don't know the answer.
You don't know the answer. Okay, now you can. We can talk. So you can answer. It's not necessary to write as it was with the fourth course. So you can ask me questions, and it is important term because what was the term for malignant epithelial tumors? The term that we use for malignant epithelial tumors
is carcinoma.
It is carcinoma, exactly. So just after you answer, switch off the microphone. Okay? So for the epithelial tumors, the benign can be either adenoma or papilloma, depending whether there is gland formation. Malignant epithelial tumors, the term that we use is carcinoma. For the malignant mesenchymal tumors, the term that we use is sarcoma. So S-A-R-C-O-M-A, sarcoma. It is important because you can understand from the term, from the diagnosis, what is the origin of the tumor cells. Do you know what are the criteria for to say that a tumor is malignant in general? How we decide? The most important is the histology, because the criteria are on the histology.
It's irregular. It doesn't have like a capsule that surrounds him in the tissues. There is a new formation of blood vessels and maybe metastasis.
This is on tissue level, and for the metastasis on organ level. And now my question is how we can decide when we look the histology of the tumor.
The cells have different shape and size.
This is absolutely true. We can see that there is problem in the differentiation of the tumor cells, and the term is that there is a cellular atypia. And there are three criteria for cellular atypia. The first is cellular polymorphism. That's what you said, that there is difference in the form, in the shape of the tumor cells, of the content of the cytoplasm. Sometimes, if you remember the renal cell carcinoma, it was with clear cytoplasm. So it is important to understand what is cellular polymorphism. Usually the nuclei are darker than normal. The term is polychromasia, and it reflects the different DNA content of the tumor cells. And also there are a lot of mitosis, including atypical mitosis. Atypical mitosis are those that are 3 or quadripolar, so you don't have the normal band of mitosis that you can see. Okay, this is in general. These are the criteria for all tumors that we use to say whether a tumor is benign or malignant. I will review them again. This is the cellular atypia, and it includes polymorphism, polychromasia, and atypical mitosis. Is it clear up to now?
Yes.
So, discussing the mesenchymal tumors, we should add some more criteria that can alarm us that there is something wrong within the tumor. For example, you can have pronounced cellular polymorphism, but it can be because of degenerative changes in the tumor cells. So it's important to differentiate whether this is really cellular polymorphism or these are just degenerative changes. The proliferation rate of a tumor is also important. So very often we should count the number of mitosis for these mesenchymal tumors for 10 high power fields. This in our biopsy routine practice. So the number of mitosis, the pleomorphism or polymorphism of the cells is important. Do you have some ideas what can alarm us looking at grossly on mesenchymal tumor? What alarm us that it can be malignant? First of all, the size of the tumor is important. For example, some tumors that arise in the retroperitoneal space, they can have really a very, very large number. They can be large with very high weight of the tumor. And it is difficult sometimes to evaluate whether there is infiltration of the capsule. It's absolutely right that you said that the benign are capsulated, most of them, but it is difficult to evaluate this material. When you look at the histology, sometimes we should examine the whole tissue. The rule is that each centimeter of a mesenchymal tumor should be examined, not to miss malignancy. For example, if we have a large retroperitoneal mass, which is 20 centimeters, how many tissue blocks we should have? At least 20. One block for each centimeter. It is important, and we are interested in areas that look different. For example, if there are areas of necrosis, areas of hemorrhages, areas that look like infiltration in the surrounding tissue, this is the role how we examine these tumors. Okay, so is it possible to grade the tumor? What does it mean, grading? Grading of the tumor is an important prognostic factor in general for the malignant tumors. It says how well the tumor is differentiated. For example, if you have a tumor which resembles absolutely the normal tissue that it originates from, it should be well differentiated. Those that are difficult to say what is the tumor, the tissue that they originate from, because they are very polymorphic, they don't resemble any normal tissue, then probably it is very high-grade tumor, and in our routine daily work, we do immunohistochemistry sometimes to prove that this is epithelial or mesenchymal origin, or further to differentiate what exactly is the tumor. But even for those that resemble the normal tissue that they arise from, we can use the grading system, either 2, low and high grade, or 3 grades, well, moderately, and poorly differentiated, and it depends on how the cell resembles the tissue that they arise from. So this is the cellular polymorphism. What is the mitotic count per 10 high power fields, and whether there are areas of necrosis or not. And in for the first slide, if we have a fibrous tumor, which exactly resembles the normal fibrous connective tissue. What was the term for the benign tumor? You had it yesterday, I think.
Epithelioma?
No, epithelioma says that it starts from epithelial, and we don't use epithelioma because it doesn't answer the question whether this is from the covering epithelium like squamous epithelium, then it should be papilloma, or it is from glandular type of epithelium, and then we use the term adenoma. Review the terms because they are important. You have a lot of information using properly the term. So papilloma, adenoma, carcinoma, adenocarcinoma, you should be aware what this term says. So if you have a benign tumor from the fibrous connective tissue, the term should be fibroma. Yes. For the malignant, what should be the term? We've said that
Fibrosarcoma?
fibrosarcoma, exactly. This is the correct answer. So if we have a fibrosarcoma, do you see the slide?
Yes.
That's great. So we'll start from the low magnification to see what are the type of cells, how they are arranged, do they form some structures. And here, this is a fibrosarcoma. If you see that these tumor cells form fascicles and they cross in the fish flesh type or like a herringbone as you prefer, and this striation can be seen even grossly on the cut surface of the most of the sarcoma. So grossly we can suspect that this sarcoma because of this fish flesh appearance. So now looking at the histology, what are the type of the cells? Can you try to what is their form?
These are fibroblasts.
How did you catch that they are fibroblasts? You're absolutely right. But what makes you think that these are fibroblasts? What is the form of the cell?
Because they are elongated. They are like
They're
spindle-shaped.
elongated, spindle-shaped. Exactly. This is the key word. They are spindle-shaped with pale eosinophilic cytoplasm. They have more plump, more large, and more pale nuclei than we expect comparing with the mature form of fibrocytes. So fibroblast is the correct term. What do you think? If we compare with the normal fibrous connective tissue, do you think we have more cells here? It looks more busy. Too many cells for the view. Agree with that? What is the term that we use for this?
Hypercellularity?
Exactly. So hypercellularity is important for the fibrosarcoma. And then we'll continue on a high power field to see whether there is polymorphism or not. What do you think? Do the cells look exactly like one to another? Look, for example, at this cell. Do you see my pointer? Do you see the arrow?
No.
No? Now? If you don't see the pointer, it will be a problem. What do you think? Do you see this cell? You don't see the pointer? Okay, it will be a problem if you don't see the pointer, but I'll try to do my best. So the cells look different from each other. There is difference in the size, different in the shape. The nuclei are with different blue color. So there is both polymorphism and polychromasia. And because you don't see the pointer, if you look from the center of the screen towards 8 o'clock, in this direction, there is a nice triangular mitosis. It is a typical tripolar mitosis. Do you see this mitosis? I'm pointing it with the arrow, but You said you don't see it. And there is another mitosis. Try to see how many mitoses you have on this screen. 1, 2, and 1 tripolar. 3, another tripolar mitosis here. 4. It's 4 mitoses per high power field. I'll try to have higher magnification and to put the mitosis in the center. Do you agree with the polymorphism on this high power field? That the cells look different? Do you agree?
Yes. Yes.
Okay, this is important to be able to differentiate. And now I'll put a mitotic figure in the center. These are the mitoses that we count. Oh, it just expands. Do you see it? It's just in the center, a nice mitosis. You can see the direction is perpendicular to the direction of the nuclei. It's just in the center, a nice mitosis in the center. We'll try to find another one. So it is not expected from you to count the mitoses, but you should be absolutely aware that we need to count the mitoses here in the center. Do you see this another mitosis? It is probably in 4 directions, so it can be quadripolar mitosis. It makes us sure that this is really malignant tumor. If there was no polymorphism, it really helps a lot. So reviewing the slide, just a moment to adapt for the low magnification. You will see that in this slide you have no area of necrosis, no hemorrhages, but polymorphism is well seen, and there are a lot of mitotic figures, so a diagnosis of fibrosarcoma can be made. Do all of you agree with this fibrosarcoma diagnosis?
Yes.
Yes.
Okay, and now next question. Can you recognize which is this organ? There is some dark pigment here around the vessel, and this thing alveolar structure. Yes, this is a lung. So we have a metastasis within the lung from the fibrosarcoma. Because fibrosarcoma rarely occurs in the lung. Which are the most common primary sites? If we have this patient for diagnosis, we should say, and with no history of previous surgery, and we diagnose this fibrosarcoma, for the diagnostic purposes, I will exclude all other mesenchymal tumors with immunohistochemistry.
Maybe breast cancer can be one reason.
Cancer is not a term that is proper to use in the pathology, because cancer usually is addressed for epithelial tumors. It's better to use either tumor or neoplasia. Okay? Cancer, forget it. You should use sarcoma or carcinoma. In this case, it is sarcoma. Where can be the primary site?
Maybe breast, because it can give metastasis to the...
The most common malignancy in the breast is carcinoma.
Carcinoma.
It's of epithelial origin. It's either invasive ductal or invasive lobular or some special types. Some of them you know, like mucinous carcinoma. So fibrosarcoma is not a term that I will address to occurring in the breast. Most of the mesenchymal tumors in general occur in the extremities. So it can occur in the lower extremities, more common. It can originate from the bones there. It will be infiltrative. Some of them will occur, for example, in the femur. It's the most common location. Tibia, in the mandible jaw, the lower jaw can occur. Sometimes in the retroperitoneum. So,
And doctor, sorry, also sarcoma Kaposi can be one reason in this
sarcoma Kaposi is another tumor. So it's of another region. Now we are discussing those malignant mesenchymal tumors that originate for the fibrous connective tissue. So tomorrow we'll have an exercise, and I will be really very happy if you try to make a classification of the mesenchymal tumors, because we have, this is the classification that we have benign tumors, malignant tumors, but also for the mesenchymal tumors, it's important to remember that there is an intermediate group. The intermediate group is very important because it can produce local recidives, relapses of the disease. After the surgery, it will occur again on the same place where it was, but they will not produce metastasis. And these tumors are very interesting, but they cause serious problems for the treatment. So I really recommend you try to make a table writing which are the terms for benign tumors, for the intermediate group, and for the malignant tumors. For example, now we are discussing the fibrous connective tissue tumors. Benign is fibroma. A typical example is fibroma that occurs in the ovary, for example. A malignant tumors is fibrosarcoma. This is the slide that now we are reviewing. But it is able to metastasize. Even the slide is from lung metastasis. But also, there is a large list of tumors that are intermediate in malignancy for the fibrous connective tissue tumors. These are different types of fibromatosis. These are this intermediate group is the desmoid tumor. Desmoid tumor usually occurs in multiparous with many children, women that occurs on the within the rectus abdominis muscle. And it is very difficult to have because it is infiltrative pattern of growth. It is very difficult to have a real clear surgical margin. And that's why it relapses. It can occur in the pelvis, again, usually young female. And you can imagine what will happen with this desmoid tumor deeply infiltrating in all organs and structures in the pelvis. So please do your best. Try to make this table and send it on the email that you have from the medical university. You can address it to me. So for tomorrow, I will have time to review and probably we'll discuss which is the best classification, not to miss any term, and to have no problems to make differential diagnosis between different types of origin of the tumors, and with the terminology which is benign, which is in the intermediate group, and which is malignant, and to know exactly what will be their behavior. Okay?
Okay, Professor.
Okay, I'll be really very glad if you do this because I'll have backup how well you understand what we were demonstrating. Okay, so I really recommend you start from the low magnification. I will review the slide again. This is fibrosarcoma. It is fibrosarcoma because it has these fish flash fascicles that cross each other. When you look on a high magnification, you have the spindle-shaped cells. It is well differentiated because they really resemble the normal fibroblasts. So there are a lot of mitosis, there is polymorphism, so there is no doubt that this is a malignant tumor. Okay? Do you remember what was the role to differentiate between fibroma and leiomyoma from yesterday? Because in both smooth muscle origin and fibrous connective tissue, you have in both cases these spindle-shaped cells. How we can differentiate?
Via Van Giesen stain?
You can do Van Giesen staining. This is very good approach, but if you have just the hematoxylinosin specimen, then I will recommend you go on high magnification and look at the edge of the cells. If they are cigar-shaped, it should be leiomyoma. If they are elongated, it should be fibroma. The same rule can be used for the diagnosis of to differentiate between leiomyosarcoma and fibrosarcoma if they are well differentiated. Just for a moment, we have another slide from fibrosarcoma. It can be a little bit different. It's good to see more than one case to discuss. It looks different. It's more eosinophilic. It's technician problem. Again, fascicles, again, these cells. Sometimes it helps if we find the areas with collagen production. You can see areas of hemorrhages in the center, areas of necrosis. If we compare the two slides, those that we previously discussed, it was well differentiated. This is more poorly differentiated comparing the two slides. And which is this organ?
Kidney.
Kidney. Okay, so probably this tumor is within the retroperitoneum and it infiltrates to the kidney structure. Okay, so another location for the primary site for the fibrosarcoma. Okay. If it is for diagnosis, I will use immunohistochemistry to see whether it's not leiomyosarcoma because these tumors can also be found in leiomyosarcomas. Do you know what type of immunohistochemistry I can use? What you recommend? Smooth muscle actin will be positive. Heavy chain mucin, desmin, these are the markers, the antibodies that will be positive. So, going further, I think it will be good if we discuss the slide, what we see, and then we'll try to make the final diagnosis. So this is the low magnification. And what we see are, what is the architecture of this tumor? Some suggestions? Is it again fascicle pattern? There are some whorls also, like here. You don't see my arrow yet. I'll put in the center an area of necrosis. It is coagulative type of necrosis. Do you see it?
Yes.
Okay,
Yes, yes.
great. Answer, please, because I don't feel very comfortable when I don't see your eyes. Okay. So here another world spindle-shaped, forming whorls, and with a small area of necrosis in the center. A lot of hemorrhages are seen, as you can see. Okay. So going on a high magnification, let's see what's going on. The tumor is composed of spindle-shaped cells, and if you look at the longitudinal section cells and fascicles, you can see that the form of the nuclei is different comparing with the previous slide. They are more cigar-shaped. Do you see it? I'll go further because it's important criteria if we have just hematoxylin eosin. Do you see with the end of the nuclei with their cigar shape? Do you see the arrow? Not yet?
No.
No, we cannot see them.
Okay, I put a nice cell in the center. It is a little bit more dark stained, and you can see that these two cells are with cigar-shaped nuclei. Is there a polymorphism of the cells? Yes or no? Do they look similar to each other, or some of them look ugly and different?
There's
What do you-
polymorphism.
It is important decision because on the polymorphism of the cells, we saw a lot of necrosis, we saw hemorrhages. It is important to have the polymorphism to be absolutely sure that it's malignant. What do you think?
Yes, it is.
Yes, it is. Especially in this area, you can see there are even multinucleated cells in the center, two cells, one with slightly eosinophilic cytoplasm. Okay. And the third criteria, if you remember, these were the mitosis. There are a lot of mitotic figures here. Just a moment to focus. Okay. I'll put a mitosis in the center. You have two mitosis, and one is three polar mitosis. So for sure, it should be malignant. And with the cigar-shaped nuclei, with a fascicle pattern of growth, and with these strange cells, what do you think? What should be the diagnosis? Is it originating for the fibrous connective tissue, or it is originating from the smooth muscles? Some suggestions. The cigar-shaped nuclei were typical for the smooth muscle cells.
So it's leiomyosarcoma?
Yes, exactly. And I'll tell you one more secret. In the most of the leiomyosarcomas that you have for your exam and for the practical, you have cells that are very bizarre looking, strange looking, large cells, very polymorphic, like this one in the center. Do you see how large it is? Sometimes, as I say, you don't need a microscope to see these large and ugly cells. And that's why in previous times they used the term sarcoma polymorphocellulare because the polymorphism is really so severe. So leiomyosarcoma is the correct diagnosis. And another slide from another tumor, which is again leiomyosarcoma. Well, it's a little bit thick, the glass, so it take more time for focusing. Here it is. So if you see such an area, have you seen such a cells? Do you see how ugly they are? They are large, multinucleated. In one of them, you can see intranuclear inclusion, probably from the cytoplasm. There are no cells to look like each other. Can it be benign?
No.
No way. Yes, exactly. I think this is the best slide to understand what cellular polymorphism means. And in most of the slides from leiomyosarcoma, you'll find these bizarre cells that it's not degenerative atypia. These are aggressive tumor cells infiltrating. Here another nice area for this leiomyosarcoma. So the diagnosis of the leiomyosarcoma is not difficult to be done in this area. So where leiomyosarcoma can occur as a primary site of origin? In which organs? In the uterus, yes, it's a really common malignancy in the uterus. Other possible locations?
Skin of extremitas.
Skin, well, it can originate from the smooth muscles that are around the hair follicles. There are normally smooth muscle cells, so it can originate from there. So it can be found as a skin tumor. It can start from the retroperitoneum space. Do not forget it. It can start from the large veins, for example, in the retroperitoneum, from the vena cava. It can start from the veins in the extremities also. So vessels are important primary site for this tumor to occur. And you mentioned that if we hesitate between leiomyosarcoma and fibrosarcoma, Van Gison staining will work. It will be negative for the leiomyosarcoma, but also for these strange-looking areas. And if the whole tumor is like that, we use immunohistochemistry because we should differentiate with other tumors that are not included in your program, like undifferentiated pleomorphic sarcoma, melanoma, other malignancies can look like that. So that is for the differential diagnosis. And if this tumor starts from the vessels, or whatever it starts, there is some difference in the way that sarcoma metastasize. They do not like to invade the lymphatic vessels. They usually first invade the blood vessels. That's why the first metastases are blood-borne metastases. If you have this leiomyosarcoma originating from the extremities, the first metastasis will be within the lung. Okay, leiomyosarcoma rarely can originate from the gastrointestinal tract. In the gastrointestinal tract, where you have large area with smooth muscle tissue, most of the tumors that resembled leiomyosarcoma was found to originate from the pacemakers of the gastrointestinal tract. These are the Cajal cells. And now they are known as gastrointestinal stromal tumors. They have different immunohistochemical profile. They are positive for c-KIT. They are positive for the DOG1, which is discovered on GIST. And these tumors have a target therapy. So for the gastrointestinal tract, it's really very important to be aware whether this is leiomyosarcoma or this is gastrointestinal stromal tumor which is from the Cajal cells, because the approach for the treatment, both surgery is preferable, but we don't have target treatment yet for the leiomyosarcomas. We have such for the gastrointestinal stromal tumors. We'll discuss this in the fourth course when we discuss clinical pathology. But take in mind that even rare leiomyosarcoma can start from the gastrointestinal tract. So to review, it will start to originate from the organs where normally you have smooth muscle tissue. And of course, uterus vessels will be the first that should be mentioned. Okay, do you have questions for the leiomyosarcoma? Yes, no?
No.
No, thanks.
Can we go further?
Yes.
Another interesting tumor. I recommend you to train when we discuss, some of you to try to describe what we see. It's a good area to start from. Irene, can you try to describe what are the types of cells that we see here in this light? Irene, do you have a microphone?
Yes, I do. Yeah.
Okay, let's go. Let's train you.
I'll be honest. I'm kind of struggling.
Start from somewhere. For example, what is the architecture of the tumor tissue? There is a slight fascicle formation. Some of the cells are spindle-shaped. Is there cellular polymorphism?
I think so, that there is some polymorphism.
There is polymorphism for sure. There are also some mitosis. What is interesting for this slide is that we have this, I'll put this violet thing in the center. What was violet on hematoxylinosine, this amorphous material? You should know it. We have seen it in many slides. It's a little bit like dust here. It is calcium. And also around this calcium, you have a pale eosinophilic material, which is bone formation. If we have a tumor tissue which is able to produce bone, what should be the term for that?
Osteosarcoma?
Osteosarcoma is the correct diagnosis. Okay. What we know about the osteosarcoma, it is interesting disease. It have two peaks of the disease. One is in the children group, usually occurring around in the long bones around the knee, the distal part of the femorus or the proximal part of the tibia. And in 1/4 of these patients, they are usually, boys are more commonly affected. We have metastasis already, which will be the organ affected first from the metastasis if it occurs in the distal part of the femorus, following the way of circulation of the venous flow.
Testis or kidneys?
Why?
No.
The venous blood from the extremity will go through vena cava inferior, and the first organ that it can see these tumor cells
Oh,
is
it's lung.
lung. Yes,
Yeah.
that's why for all sarcomas, lung is the first organ that should be examined for metastasis. It is useful to remember the ways of metastasis and just follow the circulation. Of course, you can have a retrograde metastasis, and that's why through vena cava, it can, if you have a very high blood pressure in the right part of the heart, you can have retrograde metastasis to the liver or to the kidney, but this is not the rule. If we have a young boy, we do not expect to have these problems, okay? So the first metastasis will be in the lung. And the second peak of the disease is for the middle-aged patients, usually around 45. These are usually men with Paget's disease, which is disease of the bones. And this disease is very common for patients with mutation in the retinoblastoma gene. Those children that had history, especially retinoblastoma is a tumor of the retina, which occurs at a very early age. And sometimes enucleation should be performed for the treatment of this patient, or local radiotherapy if it is bilateral. And this is a rare disease, but it gave a lot of study of this retinoblastoma, gave a lot of information for the knowledge of how the tumor cells dysregulate the normal cell cycle and how trigger the progress of mitosis, and to stay in proliferation, not to stay in the stable state like normal cells. So these children with history of retinoblastoma, they also have high incidence of osteosarcoma to occur. So there are different histological types of osteosarcoma. This is the fibroblastic pattern. That's why the fascicles were formed. Sometimes in some other histologies, you can see predominating the osteoblast cells. So different criteria and histological description can be made. The classification is very long. There is a chondroblastic type where you can find more cartilage, and this is the differential diagnosis with chondrosarcoma is really very hard. There are some vascular types with a lot of dilated blood vessels, and at the first look it imitates a vascular tumor. But if there is bone formation, it's usually primitive bone, then it should be diagnosed as Teleangi ectatic type of osteosarcoma. There is small cell type, giant cell type, a lot of histological types. And the most important metastases are in the lung and in the liver. So, to review for the osteosarcoma, the most important thing to remember is that you should see this primitive osteoid to be formed by the tumor cells, and then the diagnosis should be osteosarcoma. Besides starting from the metaphysis of the long bones, it can be found in the other bones also, but it can be extraskeletal also. It can start from the soft tissues, this osteosarcoma, which is more rarely, but it can occur. Okay, do you have questions for this slide? Do you want to see, I'll show another slide. It's always good to see different specimens. They look different, but we have the same diagnosis because Here it is, a primitive bone formation. You can see this primitive bone here. And it's good that we show this slide. You have this slide for the practical exam if you have exam next year. What is difficult in this particular slide is to find the tumor cells, but here they are. There are some giant cells here. In between the bone, this primitive bone formation, there are a lot of blood vessels, and here they are elongated like osteoblasts. Some resemble elongated, this fibroblastic type, but they produce bone, so the diagnosis should be osteosarcoma. Here again. And I think I have even one more slide. It's probably from the jaw because it is curettage. You know that sometimes first we have some bone destroyed for diagnosis. And you can see this osteosarcoma here. It is a nice slide. We have normal bone. You can see the normal bone in the lower part and compare with the bone formation in the whole side. You see the difference and what a primitive bone means. The whole screen is with primitive bone. Just this lower part is with the normal bone. Do you have questions for the osteosarcoma?
No.
Do you feel more? No. Okay. Let's go further. The last slide to discuss is liposarcoma. Liposarcoma is the most common sarcoma in adults. It usually starts in the retroperitoneum. And of course, in the retroperitoneum, it will be very large size because you have a lot of free place to grow for the tumor. And usually it exceeds a kilogram when the first symptoms of the disease. So, you had lipoma yesterday. You remember? And it looked exactly like normal fatty tissue. The difference between the normal lipoma and the fatty tissue is that the lipoma was lobulated. Now, what we see on this screen is that we have these fatty cells with different size, but in between, as some of the cells with the foamy cytoplasm, I'll put such in the center, they are called lipoblasts. They're very primitive. Do you see within this fibrous connective tissue, we have a polymorphism of the cells. We can have multinucleated cells that will look like a bouquet. Here it is one. So for this particular slide, it is an atypical lipoma, also called lipoma-like liposarcoma, but it is really well differentiated liposarcoma because the polymorphism is well preserved. Usually, as deep in the tissue is located the liposarcoma, it's more poorly differentiated. There is a good atypical mitosis. If you look from the center toward 5 o'clock, it is quadripolar mitosis. It's good seen. Beside the retroperitoneum, the liposarcoma, I mentioned that it can occur in the extremities, but also it can occur in the hidden region. So the differentiation can be quite different. And the histological diversity is really severe. And the most important cell is the lipoblast. Here it's another slide. You see how different it looks? There are few remnants of fatty tissue. It looks like infiltration of the fatty tissue from these very small cells. But if we go on a high magnification to see, these are cells that have vague resemblance to the fatty cells. They are vacuolated, they are foamy. So the polymorphism is really very high. And this is the small round cell component, which is commonly found in the liposarcoma, especially in the myxoid type. And it has an impact on the prognosis of the patient. Look at the vessels. I'll put a vessel in the center. These chicken wire, very delicate vessels, like capillaries, that are typical for the lipoma, are still well preserved for the liposarcoma. So there is no problem to diagnose. And here you can see a lot of different lipoblasts on the screen. And it is another slide I'll show you. It's a 46-year-old patient. It's one my biopsy from the previous week with third recidive of the disease. Do you see this myxoid material? It is very typical for the myxoid type of liposarcoma. And in some areas, there were very nice lipoblasts. That's why I've taken this slide just for the demonstration. And I think it's a good slide because these cells with the vacuoles within them, they have some resemblance to the normal fatty tissue. So a diagnosis of liposarcoma can be made. So she started the disease 8 years ago, and this is the third recidive. And this is the myxoid type of liposarcoma. And because the prognosis is still in control, because the amount of the small round cells is not really high, but in the surgery is still possible. We don't have good target treatment for the liposarcoma, so after it cannot be resected, probably she'll have progression of the disease. Up to now, she had no metastasis from this liposarcoma, which is also good news. So remember that for the liposarcoma, more often you have local relapses of the disease, especially in the retroperitoneum, that can kill the patient even without metastasis. So I think that we've finished with the slides, but do not forget that in the group of these mesenchymal tumors, you have other tumors to know. For example, you have striated muscle tumors like rhabdomyomas, and the malignant counterpart should be called rhabdomyosarcoma, common tumor in the children's group. You have also vascular tumors. You had yesterday a benign vascular tumor. What was that? Which was the benign tumor vascular region that you had yesterday?
Endothelioma.
No, it was a demonstration in the liver.
Hemangioma.
Hemangioma cavernosum hepatis was your diagnosis. And if the endothelial cells that proliferate are malignant and the tumor is aggressive, then how you call this sarcoma?
Angiosarcoma.
Angiosarcoma, exactly. But there is an important entity that you should add to the to the malignant vascular tumors, and this is Kaposi sarcoma. For the Kaposi sarcoma, you have spindle-shaped tumor cells, and the erythrocytes flow in between them. There is no tendency for lumen formation like in the angiosarcoma. So Kaposi sarcoma is important for HIV-positive patients that have co-infection with herpes virus 8. So you should add this. And between the hemangioma and angiosarcoma, you have also an intermediate group of tumors that are hemangioendotheliomas, which are very important. And also for discussing the tumors of vascular region, there are tumors that can originate from the pericytes. These are the cells that are responsible for the control of the microvascular permeability and for the blood flow at the level of the microvascular. You have glomus tumor, you have angiomuepithelioma or perivascular tumors. So I think and really insist to make this classification to see the great diversity of the mesenchymal tumors. So I recommend, it will be good, we have time, it's 11 minutes past 11. Do you want to have 15 minutes break? And then we can continue with the 3 slides from the hematological malignancies. So tomorrow we'll have time to finish with the tumors of the nervous system and then to review if you have problems with the diagnosis of the slides, we can make a discussion. Do you have another class now?
No.
No. Do you mind to have 15 minutes break and then to continue with the hematologic malignancies?
Okay, no problem.
Okay. So we'll see after 15 minutes. We'll start 11:25.
Okay.